Well, it looks like we have quite a few people on, so we're going to go and get started. Hello, everyone. My name is Corey Lambertson with ASIGA. I'm the General Manager of the Americas, and today I have the pleasure of introducing a true friend of ASIGA, Dr. Brandon Stapleton. Doctor, how are you?
We're good. A little hectic at the end of the day, but we made it. We made it to 5 o'clock.
That's all part of life, and we can't thank you enough for joining in, and especially for even having a crazy day of taking the time to spend with us. And so before we get started, Doctor, I want to give your bio to the audience and also introduce the topic that we're talking about. I'll also cover our objectives for the course, and then the floor will be yours. And so today's webinar, which is something I'm extremely excited to learn more about, is the modern approach to maxillofacial prosthodontics, specifically focusing on a 3D printed hollow bulb obturator. I always fumble when I say that. I don't know why, but I just really do.
Say it 3 times fast.
I can't. Before the webinar, I tried. A little bit about Dr. Stapleton. He is the owner of Identity Dental Studio based out of Lexington, Kentucky. In his background, he actually grew up the son of a coal miner and a dental assistant in eastern Kentucky. He was the first of his family to seek a doctorate level education and is proud of his roots and heritage, coming from a rural working class family. Dr. Stapleton is a proud alumni from Alice Lloyd College, a one-of-a-kind institution located in the heart of Appalachia. I probably butchered that, so I apologize.
Which you can say it either way.
Yeah, where's that close to? I guess what cities?
So Pikeville, near Hazard,
yeah, so
Kentucky. Yep. At the very tip, where kind of Kentucky, Tennessee, Virginia, West Virginia all meet.
Absolutely. So that really is the heart of Appalachia.
Yep.
So just to go a little bit further, Dr. Stapleton is one of the first specialist to graduate from the University of Louisville's reinvigorated prosthodontic residency program. This is the only program of its kind in the state of Kentucky, and it's celebrated for producing some of the finest specialists in the whole United States. Dr. Stapleton is board eligible through the American Board of Prosthodontics, and he also has earned his doctorate in dental medicine, a certificate in general practice residency, and a certificate in prosthodontics, and a master's of science in dentistry from the University of Louisville. I mean, that's a wonderful lineup that you have there, Doctor, and you can see that you already have a great foundation.
I spent too much time in school.
Yeah, way more than I did. So let's talk about our webinar. So today's webinar, Dr. Stapleton will be reviewing the history of the hollow bulb or of the obturators and their use in maxillofacial prosthodontics. He is also going to cover the pros and cons as it relates to manufacturing processes. The objective of the course is to demonstrate the effectiveness of the hollow bulb obturator with modern 3D printing technologies and the improvements of resins available to 3D print with. This has brought us to a moment where the 3D printed obturator can actually serve as a definitive maxillofacial prosthesis, which allows for weight reduction and a clinically acceptable aesthetic outcome. And so the overall goals with Dr. Stapleton today, we're going to cover the uses for obturators in a clinical practice, how to set up a digital design and create the actual design files. We're going to cover how to hollow the base before printing because, as we'll see here in a minute with Doctor's presentation, these are quite big or quite large dental prosthetics. And then how to load the file into a 3D printer and actually go on to the final processing of this actual application. Well, Doctor, thank you so much. I'm going to turn it over to you. The floor is yours. And also for all of our attendees, if you have any questions, please feel free to ask them. We'll go ahead and answer those at the end. And then also, we do have CE approved for this course. So if you are a certified dental technician and you need CE, we will be sending out an email to all of our attendees so that we can get you qualified for the credits. All right, Doctor.
Can you see me there?
Yep, I can see it is in a, it's not in a, I mean, we can see the slides on the left, so there we go. Perfect.
Better. It wasn't full screen. I don't know why, but okay. Well, Corey, thanks for inviting me. I've known you for quite some time, and it's been a pleasure getting to know your new role and all these awesome things you're going to do for us there at the new ASIGA headquarters in the U.S. So congratulations on that.
Thank you.
So just going to kind of reiterate a little bit of what Corey had said, but I'm from Eastern Kentucky, Prestonsburg. I grew up there. My parents were teenage parents, and we did. My dad was a coal miner, so he did well based on current standards and the amount of education he had. He did really well because he never finished high school. And we never really didn't have things, but we didn't have all the nicest things, So went to Alice Lloyd, free tuition. All we had to pay for was room and board. And they pitched in for dental school and residency. So it was really awesome. I'm very proud to have gone there. And, there were 100 other folks in my graduating class, and I would say at least 30 of us are doctors, lawyers, nurses, chiropractors, optometrists. So they have a very high percentage of medical professionals that come out there. And then, U of L Dental School, GPR, prosthodontics. I opened my own practice in 2015 and then moved on into actually opening my own lab here within the office that it's an independent business by itself now, just as of this past year. So we're moving and shaking over here.
Yeah, that's awesome.
This is just some shots of my families, my little furry friends, Ruby and Cooper. Cooper, the wiener dog, he's been with me since in between first and second year of dental school. So he's going on 14 years old. He's getting as gray head as I am. So,
yeah.
And then my partner Lee and my parents and my sister and my nephew over there. So got to give a shout out to those folks. And then also these guys, all the folks I trained with at U of L, Dr. Morton, Dr. Harris, and just a whole list over here of folks that I lean on, and they help me even to today. If I need a slide for something, I've got a couple slides I had to borrow just for obturator current photos, just to kind of give you guys an idea of how every obturator is different and unique. But I always like to pay tribute to these guys because there's nothing worse than something that you did showing up in somebody else's presentation and your name not even getting mentioned.
Yeah.
And ask me how I know that. So it sucks. So I like to try to keep a running list of anybody that's helping me on stuff, and I can't thank my team here enough. We started Jessica over here, my treatment coordinator. She actually is my mother, and it was just the two of us for the longest time. Then we added Kylie, and then we just keep growing and growing, and then of course now we have the lab. We just added a new technician, so we've got 3 technicians now, and Brandon seems to be the name of the game. So
I see that.
There are alternative meanings to "Let's Go Brandon." So we have a more positive
more positive approach to that.
More positive approach to that, because I even had a doctor today text and say, "Hey, I got a message that Brandon called, and just give me a call whenever you're available." I was like, actually, it probably was one of the other Brandons. It wasn't me needing something; it was one of them. So we're just still getting used to all the Brandons around here. And just a little brief introduction to kind of my technology and where I started. In 2000, I had to text my sales rep and say, "Hey, Sherry, when did I buy this printer? I don't remember." And she's like, "Man, you just jumped all in." So I got the intraoral 3-shape. I bought the lab scanner and 3-shape design software and the printer all within a 6-month period in 2018.
Has it doesn't even feel like it's been that long, but I guess it has since 2018.
Man, it has been since 2018. I had to confirm because I was like, it was either 2017 or 18. I couldn't put my finger on it. Yeah. And I remember that process of investing into the lab scanner and the software with the printer, and just in my head, like, can I rationally make this investment right now? Because, you know, I started from scratch. There are no other prosthodontists in Lexington, so I'm going door to door soliciting for patients, and we literally started from the ground up, and it's taken us until most recently to really get our engines up and running and roaring. But it was a slow build, and you know, for the longest time I was working part-time at the University of Louisville to kind of pay the bills while I was doing all this other stuff. So it's been a journey, and Sherry has become a very good friend of mine, and I appreciate all the encouragement she's always put behind me to, you know, keep going, because this next slide is where we're at today, and it's quite a bit. So,
Oh, wow.
right when pandemic started coming around, I hadn't even gotten the mill yet, but I'd already bought it. And here we are shut down for 8 weeks or however many weeks we got shut down. And I'm like, oh man, I just bought this mill, and I don't, you know, it's just
Yeah. A little scary, right? I
it
mean,
is scary.
it's an
It is
investment.
scary. It's an investment for sure. And this past summer, I got a second Asiga Max.
Yeah.
So I was having just some little just nuanced things. Like, I needed to send my Asiga just to get service, because it, you know, 3-4 years. I wanted Whitmix to take a look at it, just dissect it. If there's anything that needs to be cleaned, because it's been in all this dusty environment for so long, like clean the mirrors, clean the screens, all this stuff, and just make sure it's all good to go. But there's no way that I could have done that and gave it up for 2 weeks. Like,
Yeah.
no, you're not
So,
taking it for 2 weeks. So I said, Sherry, I'll buy a new one, and then you can have mine for 2 weeks. So that's what we did. So I got my new one, got it set up and going, and then I sent the original 2018 version off to be calibrated and kind of refurbished, not necessarily refurbished, just cleaned, and all the bells and whistles clicked
hey,
and
send it
good.
in for a tune-up. Yeah,
Tune up. There you
absolutely.
go.
Now, did
And
you when you first started with your first Asiga Max, when you know, right when you unboxed it, did you have any idea that you would have relied on it so much for your practice at that moment?
no,
Yeah.
no idea.
That's
No
yeah,
idea.
that's
I didn't know what I was going to do with it, but
yeah.
I knew that even before I got my Trios, I was doing, I could take a PVS impression, I could throw it in my CT scanner, and I could export an STL file from that. It
Yeah.
would invert that PVS and give me a model. And I relied on that quite heavily, but I had
Yeah.
no way of producing anything out of it other than playing with it in Mesh Mixer, because I didn't have I just had limited availability of my softwares on what I could do with it. I think at that point I was maybe doing some surgical guides,
Yeah.
maybe, but I
Yeah.
was outsourcing. I think Whitmix was printing some stuff for me. I was sending it here and there just to get things printed, just to kind of keep going. But I was like, man, this is such a pain to have to rely on somebody else for XYZ. And it was one of the most scariest investments. Meanwhile, the most valuable investments I ever made. And at this point, I would love to have a 4K, but I have no space to put it. We've outgrown our space. So we're actually getting ready to go through a renovation, and that will open up some more room to build that Asiga portfolio a little bit more. On the scanning side of things, we started with that Trios 3 wireless to move, and I actually got a really good deal on a Trios 4. So now I have both. So I have a unit ready to rock and roll with a laptop to go into somebody's practice and scan something.
That's cool.
And so the little iCam over here in the lower left corner, we have the iCam to get those implant coordinates, and we do a ton of full arch, all digital, no models, full arch zirconia, design milled, everything off of the digital stuff. So like we're really pushing our limits on some of this digital stuff. And yeah, we have some hiccups here and there, but it's all about learning and growing and modifying. And I tell you, that little poor Asiga, half of the stuff I'm like, yeah, well, let's print it again. Or, you know, like I end up reprinting things over and over again just to perfect the workflow and make it better.
Yeah. Yeah.
That's kind of what it's all about. So now I've got the 3 printers, the mill, 2 intraoral scanners, a lab scanner, the iMetric scanner. I have full 3-shape design studio. I have implant studio. I have co-diagnostics. I'm sure I'm missing things. I mean, we are, we have almost too much, but I'm telling you, we use every bit of it. Every
Yeah.
bit of it gets used. And that's the thing that was like, wow. When I added that second ASIGA, I was like, you know, we might use a second ASIGA every now and again. Well, that thing's going like we're always printing denture base and denture teeth at the same time, you
Yeah.
know, or a model and something else at the same time. So it's quite amazing how much productivity increases by just adding a printer.
The
Not to mention,
scalability of it. Yeah.
exactly. And from 2018 to when we bought that in 21, the price had come down about $3,500, if not a little bit more, which to me is amazing. Like to think that in that short amount of time, how quickly that price came down, because it's now getting it into more hands and more people are touching this thing. And the versatility of the resins, and you know, I can go on and on and on about why my printer is better than everybody's printer.
Oh, I won't
But
stop you. No.
I mean, and we'll go, I have a couple of other little tidbits along in the presentation about some other stats and things, just to kind of just titillate everybody about why I think that this is a really fantastic, versatile machine.
Yeah.
So I didn't mean to spend that much time on that slide, but all important things. And Corey, by the way, I can't see a clock or anything, so just shut me up whenever it's time for me to shut up.
No, we're going. I mean, we're right on time, right on schedule.
Okay. So I want to talk about a couple of things. I definitely want to talk about the network that I have and that I lean on quite a bit, which Corey is part of and has been part of for a while. A few of the tools that we're going to be using to do what I want to do, not only for this particular type of prosthesis, but other things that we're using. The background of the obturator, and kind of I realize not everybody understands fully what the obturator is, why we use it, why it, in my mind and for my patients, we bill it as a medical device because it is a medical device. Without these prostheses, these patients couldn't function. So, and a lot of times they're needed as a result of another medical procedure, like cancer. And then I have a case example for us to go over. And then I want to kind of dive into a little deeper into the new approach that I've kind of developed over the last 2 to 3 years, because, you know, like I said, I'm kind of the only private practice prosthodontist here in Lexington. Now there's a couple of prosthodontists, or more than a couple at University of Kentucky. And then, you know, if you go up to Louisville, there's tons.
Right.
But private practice wise, I'm it. There was an older gentleman who retired right after the pandemic, and we practiced so differently that like we didn't interfere with one another's business models. You know, like we were just night and day different. So just going over a little bit of my new approach, how I get these patients. These patients come from mostly the University of Kentucky, because while they do have maxillofacial prosthodontists and other prosthodontists over there, you got to think about in a school environment, the primary purpose of those faculty members is to teach. Their private practice side of things is more of a supplemental part-time, not even a part-time gig, just kind of most of them is just half a day a week.
Right.
I clinically see patients at least 3 days a week. And we're pretty busy. So I can only imagine the volume that they have to sift through over there. So there's just not enough capacity at the University of Kentucky for them to see all of these patients in a timely manner, because we're talking about cancer. That stuff's got to go.
Yeah.
They're not going to wait 3 months for an appointment. So I have a good relationship with Melvin Yo. He's the kind of the big guy over there in the oral surgery clinic. He's chief and head over the program and everything. So he'll call me and say, hey man, I've got this patient. I need to see her next week for surgery.
Yeah.
Can you see her today?
Yeah.
They're going to laugh at him if he calls up on the faculty members, because they literally don't have time. It's not because they don't want to, they just don't have time. And, you know, more often than not, we work them in and we, you know, we'll stay a little bit late. For me, some of it is giving back and making sure that these patients have good care, because outside of me, there's nobody else available to take care of these patients. So are these the most profitable procedures that I do? Absolutely not. They take an enormous amount of time.
Yeah, I mean, these are more extreme cases. I mean, correct me if I'm wrong, but these are, you know, special cases, and it's, you know, these cases aren't for you to make profit. These cases you're doing these because this is what you love, and you're
exactly
helping
right.
people out. I mean, this is pouring yourself into your job,
Yeah.
and making a change in somebody's life for the good.
Yep. And, you know, yesterday, you know, I've got a case that I'd love to have highlighted today, but I just don't have enough time to get all the stuff documented and get it done. But I mean, his exact situation, he couldn't wait on me because it was during Christmas and winter and all that stuff. So he went ahead and did the surgery, and then she came to me after the surgery for me to make a kind of a surgical, a provisional prosthesis, I guess, at this point. Ideally, we provide him a surgical prosthesis that he delivers at time of surgery, and then we modify it from there.
Yeah.
But my network, I can't speak highly enough of the folks on the screen, and I probably have missed somebody who helped me in one way or the other. Patterson Dental, on, you know, we kind of have an exclusive situation with them, and as much as I can buy from them, I buy from them, because they have been there for me through thick and thin. They sponsored a ton of stuff for me, either for my office or lab, or as president of the Bluegrass Dental Society or president of the Kentucky section of the ACP. So they are always there to chip in. Whit makes the same way. I could call Ann and she'd throw a check at me to do an event or do whatever. And I'm sure the same for you, Corey. Like, if I wanted to highlight you guys and do something, I know that I can count on you guys. Like, you guys are always there for me. And building a network is, that's a lot of what I've done over the past, 6-7 years, is building my network of people who I lean on to help me solve problems. So all over the place. Can't say more kind things about the people of that network. I mean, it's impossible to get things done if we don't have help. Some of my tools, we highlighted them a little earlier, but this kind of, and I'll turn that volume down a little bit. I don't really care about the sound so much. The trios really transformed my practice as much as the ASIGA has, because being able to easily capture data, and this was the Trios 3, and the Trios 4 is even quicker. Now that's a little sloppy, but I think the general idea is within less than a minute, I should be able to capture a pretty decent impression on a dentate patient. It's a little more challenging when we talk about dentures and edentulation and all that stuff, but we also push the limit in those regards too. But this has really changed the way that I practice dentistry, and I can't do what I do without this machine and my design software and my printers. The data is so valuable in capturing the palate. Oh my gosh. I don't know why dentists don't take that scanner and scan the palate. It takes an additional 10 seconds to get the palate. And they'll send me a scan like, can you make a flipper on this? I'm like, nope. You barely got the teeth. Not to mention you missed the whole palate. And for me, that landmark is significant. because I can use those palatal rugae and the palatal anatomy to align scans from 2 years ago, from 3 years ago, from, I can utilize that scan multiple ways if I have enough anatomical landmarks to utilize it.
Right.
I've gone so far as to go back to like patients coming in for their definitive restoration. And I don't love where we're at with the provisional. An immediate provisional sometimes doesn't get seated fully. You got issues clinically, and a sedated patient, maybe at midline was 3 teeth off or something crazy. I have gone back to original preoperative trio scans, align them with current scans, and been able to rectify tooth arrangement problems just by utilizing a preoperative trio scan.
Wow.
If I hadn't captured enough vestibule and anatomy, the chances of me aligning that are none. So it's invaluable data. I know we're talking to a bunch of technicians here, and they probably are like, yeah, scan the palate. And I preach the same thing to the clinicians, like, you guys are missing a huge piece of the puzzle there. Like, don't just scan 3 teeth, scan the whole arch, even if you're doing a single crown, and get the palate, because at some point in time, you might be able to use that. It takes an additional 45 seconds to get all that information. And guess what? It doesn't cost you more. Like if you did a quadrant impression out of PVS, yeah, I understand why you didn't do the full arch, because it costs double the amount of money for the PVS. So I don't know why dentists do what they do. I shake my head all the time. So I'm with you on the lab side of things, guys. For all of you lab nerds out there. And then
this might be a piece of resin, but it's ultimately someone's mouth. So getting it right and looking after that patient is super important to us.
We have good audio on that video.
We're an 84-year-old business.
Yeah, is that a good volume right there?
Dentists across Australia. We're the biggest.
You can turn it down just a little bit more if you want to talk.
The biggest in the southern hemisphere.
I was really impressed with this video. I had you guys send me some videos because I didn't really like the ones I found on YouTube. But the way that they've utilized their technology, it's pretty amazing.
The fit of the die into the model needs to be perfect.
I agree with that one too. Like how the Geller models are just effortless.
Enormous amount of research and development when we chose.
Yeah, it's pretty wild. Something I really like about this video, and it's so true. And it, as you start talking about the indication here in a few minutes, something that we all forget when we're in 3D printing is, the first line is, this might just be a piece of resin, but it's ultimately somebody's mouth. And that's so important because it is, we're working on a patient and it's crucial, and we have to get it perfect. And, as we were talking the other day, Doctor, that that's what we strive for at ASIGA is perfection, and that's why we see our printers and institutions like your facility that strives for perfection, and everything has to be extremely accurate, and the flexibility for any material. I mean, it's so crucial for that.
Well, it's an amazing machine, and well, I'll talk a little bit more about that. These are the companies that you guys have validated profiles for. Look at that. Like, that's insane. And there are no other printers on the market that have validated workflows with this many variety of people. And that's amazing to me. Like, for example, Formlabs there. You go to Formlabs website, you go to their third-party thing, they may have a couple listed. Like, I think Key Splint is a favorite of a lot of the varieties of printers. EnvisionTech has a Key Splint file that you can use, and there are several of them that have those highly sought-after resins. But like, you guys are like, oh, I want to like validate that resin. I want to validate that one and that one and that one and that one and that one, and just keep going and just adding these files, which is fantastic because as the firmwares and the softwares update, like everything just keeps getting better and better. And I love that I can go onto the portal and just download a resin even if I just want to test it out, like maybe I just want to buy one bottle and I don't want to sit and develop my own resin profile, although if you are so inclined, you can. But I just find it fascinating how many resins you guys have available, just to download and load and go.
It's literally load and go, and there's over 500, and that number grows every day. I mean, it's like when I talk with when we have meetings with the team in Australia and in Germany, it's like a constant list of materials that we're validating, and with that, we give you, the doctors in our laboratories, the ability to choose what's best for your patient. Doctor, what's best for your patient that you have in the chair right there, and
Yep.
as a 3D printer company, we shouldn't restrict that. In fact, we should open that, and that's what we do.
And that's important because long sought after, this GC temporary resin was long sought after by Asiga users because it was a validated resin. And for the longest time, you couldn't get the resin. Like you had the file, but you couldn't get the resin. But now you can get both. And I've played with it, and I like looking on this list and saying, "Oh, I want to test out that resin and kind of like see how it feels and looks." And yeah, there's some. You have your trays and things to consider, but you can always clean those if you just are using it on a one-off chance. Usually, I'll designate a tray in one of the black boxes for whatever resin I'm using, and I just kind of keep that tray with that resin until it expires. But if I'm just testing a couple of things, I've got a few trays that are available just for, let's throw a resin in and see how it does. And I've played with a lot of resins on this thing, and when it comes to, especially like you're trying to find the perfect denture-based resin or the perfect denture tooth resin, in my mind, you got to test several. You're not going to be happy with the first one you pick because they all have pros and cons. Some of them are super translucent. Some of them are just dead when you look at them. I know there's a big push now for trying to kind of elevate the printed resin, and I love that. I love seeing everybody pushing the limits on how can I make this look like ceramic or be as nice as a traditionally processed denture. Is it to that one-to-one aesthetic level at this point? I don't think we're there just yet, but every day we get better. Every time I log on to some kind of printed Facebook group, I'm seeing somebody pushing the limits on making a pink look better than it did when it came out of the printer. Yeah. And I think that's what it's going to take, is just elevating it to the next level without slapping $100 worth of composite on top of it. I'm talking about just colored resins on top of the other resins that are already there, just enhancing it and making it look better. So, I'm very impressed with y'all's library and the versatility that I have. There are definitely more than 10 combinations of resins that I could have used to fabricate what I fabricated for this lecture. So yeah. I find it very interesting myself. Okay, so just a little bit of background about obturators. Every patient is different. Every hole is different. Every indication is different. The patient on the top right just has a hole right in the middle of his palate. Their surgery was very conservative. If you could call that conservative, I would, because the patient, although the teeth are not in the best condition, he still has his teeth, which is fantastic, because guess what? Now all I need to fabricate him is a base plate to cover that and put some wire clasps on it, and that is a transitional prosthesis for him for however long he needs it. If he at some point wants to do something a little more permanent, we can. I think his surgeon has this bright idea to try to cover that up. My personal belief, and this is just me and my philosophy, I would rather have the hole, because when you start trying to do surgical procedures to cover these, you're talking about free gingival grafts from other sites. So you're taking a piece of your thigh and you're putting it in the roof of your mouth. So wow. you get hair. with that. So you get patients with hair. You also like rub your thigh right now, like it's squishy, right? It's not firm like the roof of your mouth. So if I need to put a prosthesis on top of that, how the heck's that going to work? It's not. It's going to bounce. So my preference is to leave the defect and let my prosthesis seal the defect and replace the teeth, because the defect actually can increase the retention of the prosthesis.
Wow.
Because of all the anatomy that's up in there. I can take advantage of some undercuts as long as they're not bony undercuts. If they're soft tissue undercuts, I can lean on them a little bit. So the one on the left there, like that's a huge defect. And I bet that little blob of acrylic there weighs quite a bit. And just imagine that same sized obturator filling the same size defect, but with 75% less weight. So that's kind of where we're going with these new techniques and with the printed stuff.
And it would just make it, I mean, it would increase just being comfortable for the patient, right?
Absolutely.
Well,
we're working against gravity here too. If I don't have teeth, that's a denture with a defect. So if I don't have teeth to hold on to the prosthesis, like that thing is just, we're waiting on gravity to dislodge it.
Yeah.
The one on the bottom there, that's a soft palate defect. The hard palate is intact, the soft palate isn't. So that prosthesis needs to extend into the oral pharynx to be able for the patient to be able to swallow.
Right.
Those are very challenging to capture the borders and anatomy, and for it to not be uncomfortable for the patient, because I think I'd puke my guts out every day to put something back that far in my throat. Now, most of these patients don't have that sensation any longer just because of the surgical procedures they've had. But it just in my mind, I'm like, oh man, like a denture I could maybe deal with, but like that thing going to the back of my throat, I would have a really hard time. Yeah. And I see patients regularly that have these things all the way down the back of the throat. So obturators are used to kind of fill up the space of these maxillectomy defects. So whether it's a complete maxillectomy or a partial maxillectomy, it's still going to require kind of an obturator to facilitate some of that. Some of the difficulties are swallowing. A lot of the patients, their chief complaint is, I can't eat because I can't swallow.
Yeah. Right.
So many of my patients come in with a feeding tube initially, and hopefully we can transition them out of that. They work with their speech therapist and occupational therapist and some other therapists to kind of work on swallowing and all those things. Speaking, my assistant Megan and I have developed quite the ear of being able to understand patients when they don't have their prosthesis in, because it's like their voice comes up and out, but it gets stuck. Like it gets stuck up in that hole and it can't project its way out, right? So there's no way for it to continue out of the mouth to have a conversation. So I can understand them very easily, most of the time. And Megan initially, and she's a whiz at kind of developing some of these skills, and she's kind of, I have two assistants, and she's my designated obturator or maxillofacial assistant, because not only does she love it, she's really developed a knack for communicating with the patient. She knows what they should be expecting. Like many of them will call and they won't say, I need to schedule an appointment with Dr. Stapleton. I need to come in and see Megan. And I love that, because that's one less thing that I have to do. And they are so connected with her that they understand that if she doesn't know what to do, she's going to come get me and I'm going to come in and help her. Right. But like they almost come to see Megan, not me now. And I think that's fantastic, because the more I can delegate, that's even better for me, because that's something else I can spend my time on, working in a lab or doing something to see another patient. But yeah, she almost can see these patients without me. It's at that level at this point, because we've done so many of them. Facial deformity is a biggie for a lot of our patients, and when you and I talked about me potentially doing this topic, it's like, there are so many of our patients that we haven't photographed very thoroughly because I don't want to make them feel uncomfortable with us
Yeah,
taking a
I mean,
bunch
this
of,
is
we take photos on a lot of people every
yeah,
day. And this is one area of patient where I don't push. I don't
yeah,
push the patient. I don't push Megan. I don't get mad at Megan if she doesn't take a photo because I understand that there is a huge, it's just a little more, you gotta be careful.
this is I mean, this is a sensitive case.
Exactly, especially when
Yeah,
you get these extremely vain patients and they want it perfect. And
yeah,
we can get it better, but we are far from perfect almost every time.
yeah.
And that's unfortunate, but like we are absolutely doing the very best that we can with the skills I have. I did not do the additional year of training that most or that all maxillofacial prosthodontists go through. So yeah, it's a very sensitive topic.
Yeah.
So it seals the opening and the defects, and just some examples. The patient in this lower right, like he has some recurrent things going on. That photo actually wasn't necessarily to document progress, but to document something that I wanted to show the surgeon. So he's got some fungal stuff going on there and maybe even some recurrent cancerous stuff. So you're looking at kind of the turbinates in the nasal cavity. That's what those little things look like. So the bulb kind of fills that hole and it adds in retention and stability of the prosthesis, but it does add a lot of weight, especially if we're using like the soft liners to refit it. And every patient, every defect, they're absolutely different. And there are a ton of different methods to fabricate these, and they're very customized. There are techniques to do this analog. It's very time consuming. Not that the digital stuff isn't time consuming, but it's a very laborious process. And it's inconsistently, like I can't consistently say that I get a 2 millimeter thick wall all the way around. In the software, I can tell it 2 millimeters. That's it. This is this was done 3 years ago. So I think I had to outsource the printing of that model that you see kind of inverted there for that modified impression. So this patient needed a complete denture obturator, but she couldn't open more, maybe just a little bit more than what you can see right there. It was really hard to get anything in and out of her mouth. So I had to borrow a scanner to scan the teeth because I didn't have a scanner at that point in time. And then we kind of outsourced the printing. And then I modified a model to then create the temporary or the transitional prosthesis. It was a very difficult one to do. She may not have benefited completely from a hollow one because it's not a huge bulb back there, but there's definitely an indication to use some digital technology to make these things better. If you want to read that, it's on Spear Digest. Just Google Spear Digest and my name, and that whole article will pop up. It's got a lot of photos in it and stuff. It's kind of the beginning of the digital stuff for me. Well, not the beginning, but like private practice digital stuff. Because we did digital in residency, but not as much as I do today. So this patient came to me. He has had multiple surgeries, 61-year-old male. He has had squamous cell carcinoma of kind of that central area, and it has just kept going and going and going, and everything they did to him just kept getting worse and worse and worse. They kept taking more maxilla. At some point, he had an implant or two. All of this falls back to some issues or some materials that they used while he was working for the state of New York. And so he's kind of a workman's comp case. So they do cover to some degree some of the needs that he has. It's just really hard to get them to do anything. So he came in, he needed a new upper obturator. He still has all of his lower teeth, but they're in very bad shape. And this is kind of what he walked in with. It has split once already and been repaired. You can see kind of some, this was a locator at one point in time. They've already hollowed it out by creating that part just to make it more light, but there's still a huge volume of acrylic here.
Look how thick that is.
It's extremely thick. And this was made 15, 20 years ago, so it doesn't fit him the way that it's not as intimately fitting as it should be. So when he came in, we refit it. We used some chair side soft lining material. And then I used my lab scanner and did a 3D scan of it to capture all the intimate details of that. So then I have an STL of the whole thing. And ultimately, I'm going to use that to create the master cast or the inverted cast. I call that an impression in 3Shape, and it will invert it into a model. And then I can use the denture studio to kind of, and the denture module to work through to get a new setup. Permasoft was my all-time favorite soft liner. It's amazing. It was discontinued by Dentsply when they did their huge exodus of anything analog. They're just getting rid of it. Before it came back with Meyerson, I discovered Fricky's Vitacrylic, which is a fraction of the cost, and it actually, I have to say, it's a good material. I like it clinically for just chair side relines. So we use it quite a bit. We modified their formula just a little bit to work in our hands, but it works just as good as Permasoft, and it's a fraction of the cost. For anybody out there looking for a tissue conditioner, I would say the Fricky Dental Vitacrylic is top of the notch, and you can use it in the lab too to process things, but we use it chairside to refit things. Previously, Permasoft was my go-to. CoSoft and some of those other ones just, they don't have the handling properties that I like. So the Vitacrylic and the Permasoft are my go-tos. Now I want to talk a little bit more, kind of get into the nuts and bolts of how I do what I do with the 3D stuff. So hollow weighs less. I've already talked about that. It's a printed resin, so it is strong, depending on which resin you pick and its properties. But there are some really strong resins out there that arguably are not going to just break on command. And you can uniformly manage the thickness in the software. I think it's extremely efficient in terms of creating the hollow bulb versus the analog techniques. And arguably it's cost effective because there's less labor involved. You're not investing multiple times. You don't have to boil out. You don't have all these other things going on. And then multiple layers of processing. Because if you do a hollow bulb analog, you have to process half of it one way and half of it the other, and then at the end kind of put them together. Lots of technique articles about how to do it. Here is a printed version of his new provisional or new temporary prosthesis. And there's a printed version of his new provisional prosthesis, essentially the exact same file, but manufactured two different ways. The file on the right is solid. The file on the left is hollow. The file on the left, or the restoration, teeth, everything finished, glazed, polished, everything for that photo, 1.6 ounces. On the right, the solid one is 2.6 ounces. Doesn't sound like a lot, but I had the both here in the office today, and my team were like they're like, oh my God, like I wish you could show, like have these to pass around the room, like show and tell, like to feel the difference in just such an insignificant amount of weight, how weightless it almost feels. to have that hollow one. Time to print was exactly the same because they're same height, so same layers. It's just not a full cure on the hollow one. The teeth take 34 minutes at a 0.075 millimeter layer. The cost to print the base, $15.29 for the hollow and $25.30 for the solid. But I would argue, you could argue that the printed one costs the same amount because there's some wasted resin. There is some wasted resin because it gets trapped and you have to extract it.
Yeah.
So, but even $10, not a big deal when we're talking about a prosthesis that if we were billing this, so say medically we were going to bill this in my practice as a definitive prosthesis, which I don't think that that's where this is at. This is more of a transitional or provisional one. A definitive one is about $8,500 for a medical device. For a provisional, it's more like $3,500 probably. Does the insurance always pay that? No. But that's kind of the value of what we're billing and what we're expecting to get out of it. The teeth, negligible, $3.32. And the nice thing about your software too, Corey, is the Composer software. If you input, so you do your file, you load it all up, you put your supports on it, you put in the cost of your resin per liter, and it will tell you how much exactly it's going to cost you to print that file. And that's where those numbers came from. I kind of did the little math thing. So here's my denture base STL. So like I said, I used 3Shape software to design the denture. I did it as design teeth on a printed base. I think that was the order form. And then you literally go through the denture process. Now it does get a little mad at you when it has to be that tall. It doesn't like to connect the base to the teeth. After some finagling and some yelling at the computer, it ended up working for me. But this is not a walk in the park. You can't just go to work tomorrow and start making these things, no problem. There's a learning curve for the design stuff. But it utilized that scan that I showed you of the reline prosthesis as the impression to get the contours. And I kept what was already hollow in the top of it to help with the weight issue. So I take that designed STL and I open it in Mesh Mixer. And these are the settings that I like to use. I've seen some, Dr. Lynn, a colleague of mine who was a professor of mine when I was at U of L, he's at IU now, and him and his team, they just published a study about printing these things and the accuracy of it. And they used a little thicker base. You absolutely can use a little thicker base, but the thicker you make the base, the more weight you have. I tried to play, well, I'll get to that in a minute, but I tried to play with some of the software and the supports and stuff, and it didn't work out so well. So I like a 2 millimeter thickness. I think that's appropriate. If you have to adjust a little bit, you got some wiggle room there. Now, if for some reason you had a perforation, I've got some tips on how to rectify that situation. And remember, these things are initially, for me, are transitional. We're trying to get the patient out of surgery and into something a little more stable, or we're trying to give them something. In this guy's situation, he has no maxilla. It's a hole in the top, in the roof of his mouth. He has a little sliver on either side where the tuberosities are, and that's it. So the lighter this thing is, the better. So for him, this could be his definitive. I would never charge him as the definitive, but I would still call it a provisional because that's what it is. But the feather weightness of it is going to make a significant difference for him. I increase all the way up the accuracy of the solid and the mesh density, just because mesh 3Shape has already exported the file. It needs to be as precise as 3Shape exports it. I don't want to modify or decrease the quality of that at all. I don't put any of the holes that it will allow you to put holes in it in the software, but I typically skip that step. You might save some resin if you do that step and put those holes strategically where you won't have, where you know how the build plate is, how you're going to nest it. and everything. You could save some resin that way, and maybe a couple of dollars. But I don't do that in the software. And then I just say update. Once it, you can see here, you got a halo with a darker interior. That darker interior is the part that's hollow. So anywhere that there is 2 millimeters minimum space or less, it makes it, this right here is all solid. There's no hollowness within that little flange there. But the middle, that solid color that you see there will actually be the hole or the void that it'll create, and then the halo will be the solid part. And then you just export that file. So when we import it into Composer, it'll know that it's hollow, and you'll be able to set everything up. After you export that, you can go straight into Asiga Composer and kind of build that file for the nesting. So I sped this up quite a bit because I'll tell you the processing time on the file was quite a bit. Actually, you know what? It didn't speed that up. It says that 25 minutes. So I'm going to speed this up manually. So you position your file. I usually just print these at 0.1 millimeter thickness. And then I let the supports auto-generate. Now there is an option. Let me scroll back just a little bit here. On the support, there is an option there that's clicked that says model enter support. I tried to be creative, Corey, and say, you know what? I'm going to thicken the wall just a little bit. I did 2.5 millimeters and see if it will print without inner supports, which is supports on the inside of the hole for the void. And it failed. So some files might print without it. And I even tried to figure out if there's a way to manually add the inner support. And I don't, unless you have a trick that I didn't figure out, I couldn't figure out how to manually add an inner support. I could add or remove outside supports, but not inside supports.
You should be able to add inner supports, and I can show you that.
Okay.
But
So,
you do make a great point just for the audience. So like this hollowed indication, it's not hollowed with 3D printing in mind. It just takes that exterior shell and it creates a reduction. It creates a hollow space on the inside of it. And so there could be an unsupported overhang that needs to be supported. And so by having that model inner support feature automatically turned on, the software will capture that and support where necessary to ensure success.
Yeah. When I slice it, you will be able to see those inner supports. So it did take quite a bit of time to slice everything and kind of get it all situated. So here we go through the slices. So those are the under supports. So see right here, like inside, wish I was trying to pause it before it transitioned.
You can see it briefly, the supports inside.
Let me see if I can pause it. I want it to show that. So those are the under supports. And then here in just a second, it gets to the meat of it where you got hollowness. So here, these are your external walls of your prosthesis, the dark lines. This is that hole in the middle that we intentionally left because it decreased the heaviness of it. And these supports are on the inside of the prosthesis, and those will remain there because we can't remove them. So if I did a section through the prosthesis, I'm going to see supports throughout this hollow area. Well, of course, that adds weight. Now, we flush that very thoroughly with alcohol to try to run out any of the uncured resin, and we cure it very thoroughly to cure it all. But if there was a way to reduce some of those inner supports, and it sounds like there is, I just didn't have all the tricks that you do, we can reduce that weight a little bit more. It's not going to be significant. It's already significantly reduced by doing what we did. So I thought that it was just cool to see all of those little supports on the inside. All right, so the teeth, that's easy. I think everybody probably tuning in has printed or regularly and routinely prints teeth for temporary dentures and whatnot. But in this scenario, I did double it because I'm printing a solid and the hollow one. So I printed 2 sets of teeth, but it takes the same exact amount of time to print 2 sets of teeth because this is the digital light projection, not a laser that has to march over every bit of every layer. So you're going to get efficiency with printing that. So if you got to print something, just load that plate up because it's going to take the same amount of time. Whether it, and then with some of the other printers, you load that plate up, the more you put on it, even if it's the same Z height, you're tripling and quadrupling your time because of the volume that you're printing. So that's one other nice thing about the Asiga is you can load it up. It doesn't matter how full it is from the X and Y axis. It's just that Z height that controls the time and your layer thickness. So the last thing is to kind of send those files to the Asiga. So once you have them built, I like being able, I accidentally skip the slide when I try to pause the video. I like that web portal because I can have access to it while I'm sitting across the room. I already have the print, like while it was loading up and taking a little bit longer to load because of all the slices, I had already prepped the printer to accept the file and ready to go. The resin's in, it's loaded, the build plate's there. So now I'm back at my workstation and I'm like, yep, okay, it's ready, it's loaded, ready to go. I just need to log in and tell the printer to start printing. So you go in, you select the build, and you press start. And it says, it just asks you for confirmation that this is the file you want to print, this is the resin you're using, and go. And an hour and 47 minutes later, you'll have your printed product. And then there's your teeth and your base. I didn't have any fancy videography like you guys had in that video of like the thing coming out of the resin and it's still dripping off. I need to up my game, man. So for me, for post-processing, I've tried a lot of different ways and I have a lot of things going on and I cannot sit by the timer with the ultrasonic bath and remember to get the dang thing out of there at 5 minutes. So I did invest in the form wash and I have 2 of them. One's for dirty, one's for clean. And we change those out very regularly to make sure that clean one is almost pure, clean alcohol all the time. And it has worked really well in our office and lab. I like that it has that auto eject. I've tried several other ones and just the absent-mindedness of I've got a lot going on and I cannot remember to just go back in 5 minutes to take that thing out of the ultrasonic and then it'll sit there all day and that's not good for the resin to sit in alcohol for that long. So I can put that thing in there at any point in time, press start at any time interval I want and it will be ejected by the time I come back. And the basket, actually, most of the time I can fit the whole build plate with the product on there, at least in the first wash, to get the build plate cleaned back off. So I just throw that in that basket and off to the races, and it works out pretty nice. Do you guys have any other tips and tricks on washing? Because post-processing is kind of the everything else is pretty easy. It's, post-processing and finishing is kind of where all the nuances come in to make it perfect.
It's where the dirty, I mean, that's the sticky, gooey part of 3D printing. But honestly, the best advice that we can give is to always follow the IFU for the material. And so the instructions for use for each material manufacturer is going to vary, and it will change from manufacturer to the manufacturer. Even material type within a single manufacturer may be specific or unique for that type of material. And so the best advice we give is to always follow the instructions for use. And then the next thing is use quality IPA. That is crucial because there, especially with going through this pandemic, it seems like there's been different grades, not just like percentage of alcohol in the IPA, but also just the overall grade of it. It is important to use a nice high quality grade of IPA to make sure that your prosthetics are actually truly clean after the clean process.
Yep. You don't want any residual sticky stuff on them when they come out of that second bath. It needs to be gone. So exactly what Corey said, you got to follow the manufacturers. Everybody's got their own time on each wash. So, and they also have their own cure settings. So make sure you know what you're working with. This one's cool because this little video I took the other day, I just do little pinholes. One kind of on this one, I did one in the anterior, one in the posterior, and it's like Dr. Pimple Popper kind of deal where you're like squeezing all that stuff out. So I wear my gloves and I have my IPA, my little squirt bottle, and you get a little bit out of there, and then you like shift it one way or the other, and you really get some stuff going. I like to like slide over so you can see it coming out, and then here's where the big one pops. It's like, oh yeah, look at all that goo that's coming out of there. But that's like, remember that $10 difference? That's $10 lying right there in resin that I'm squirting out of that bulb. But if you can strategically position your holes so that you can drain as you're printing, then you may be able to salvage some of that resin. But after you do this and you get it mixed in with the IPA, it's not usable. You can't recycle that resin. Once you do this, you're committed. So both
thanks
solid.
Thanks for that disclosure, because you can't recycle the resin.
You can't recycle the resin after I squirt all the alcohol in there. So then you assemble, cure, and finish. And then again, these are two different ones, same file, one's hollow, one's solid. I'm not here to try to make the prettiest printed denture. This is not me spending hours trying to finish it, but this is just kind of giving you an idea of what the product can look like. Probably not the prettiest, but it is a functional, clinically acceptable prosthesis.
No, it looks great. I mean, it really does. That looks phenomenal.
So you deliver these and they fit great, right? And then patient's tissue changes. So then what do you do? The traditional, like the Acrylic and the Permasoft, they don't like these printed resins too well, or the printed resins don't like them. One or the other. Somebody doesn't like somebody. What I found are these gel that have a primer or a bonding agent. They don't work 100%, but they work better than the other. So if we need to readapt a certain area, we may want to roughen up and sandblast and even put a finish line on that area with a burr, and then layer it back with one of these gel relines. It has been my best solution to that issue. Not perfect solution, but it is a solution. We still have to often come back and, replace those if say a fungal infection were to get on the prosthesis. Oftentimes it's hard to get it off of the gel liner part of it. Even if you treat it, it's hard to get rid of it. So we would need to remove that and replace it. And ultimately, if you're replacing big hunks of it, then I would say you're adding weight back to the prosthesis, and that's the opposite of the goal that we had in mind. So at some point, the patient needs to commit to replacing it. And that's why I don't like calling them definitive, because I like the versatility of saying, okay, well, it's been, 3 years. It's time for us to replace this prosthesis. It's not $8,500, it's the $3,500 or whatever fee you might have in your clinical practice. But it's an efficient way to refit them until the point of time to have a new one.
Right.
So that kind of, I know we're a little bit over. I'm sorry about that, but we had some good conversation there. So I see a couple of little questions up at the top. I don't know if you.
Yeah, so I'll run through them for you. So
Okay.
the the first one was kudos for your comment, and so I think that was referring to, it was earlier halfway through the presentation, and it may have been when you were talking about the capturing the full palate and
Oh,
bashing dentists, or not really.
well, I'm a dentist, so I can bash dentists, right?
Yeah, exactly.
And
The,
I promise you, I tell them all, I don't know why you guys don't scan the palate. Like, it just makes no sense to me because it costs you no money to scan the
yeah,
palate. So you can't give me that argument anymore. I understand with a PVS impression, but I don't understand with scanning something digitally. It takes, 15, 20 seconds to scan the palate if you're skilled at it.
right. The next question
I
we
think we
got.
answered that one.
Yeah, yeah. So what material do you use to reline the 3D printed denture? And so you just covered that at the very end, and so that's very helpful information. The next thing that I would add to that, let's say if, as Doctor was explaining, if you have to keep making adaptations and more changes to it, and Doctor chime in on this thought, but you could technically do another reline or a wash impression with that obturator, and then take that back to your desktop scanner, do a copy denture workflow. With that, you wouldn't have to do the full design of a denture, just do the copy denture, especially if the anatomy and occlusion is still correct.
Yep.
And then you could go through your mesh mixer, create your hollow, obturator.
It would be a lot more efficient than doing the design from scratch method.
Yeah, yeah.
And that's what and that's kind of what we all tout about the printed technology, is that it is so cost effective that it's not going to break the bank to remanufacture that product.
Right. And then I have a couple questions myself, if that's okay. Out of all the materials that you have tested on your Asiga for this type of indication, do you have a particular favorite at this point in time?
No.
No, not yet.
No.
Yeah.
No, I'm still playing. Now,
Yeah.
I've noticed probably over the last year and a half, maybe, the resins have gotten denture-based resins have gotten better and better. I think the denture tooth resins, or even the crown and bridge type resins, they're good. Sometimes they're a little brittle, but it's the denture-based resin that isn't 100%. Now, I haven't used the Asiga one, so I'm planning to play with that a little bit more. At this point, I've used almost every shade of the Dentka available and a couple others, and they work. The Dentka is a little too translucent for me. And then some of the more opaque ones just almost seem a little too dead. It's all going to require some external characterization, I think, regardless of what you use. Now, I'm curious about the Lucitone print, but I don't love the price tag on the resin and the requirement of their $9,000 curing unit. That's kind of, it's cost prohibitive entry level just to play with it. We can probably play with it, but maybe not get a full cure, so maybe not use it on a live patient, because you don't want to put a prosthesis that's not fully cured in a patient, but you could play with it and see kind of how it handles and the optics of it from the printer. I'm curious to play with that one. I'm not excited about spending that kind of money on the resin, especially when, for example, the Dentka resin, which is clinically acceptable, is half the cost of that one.
Yeah.
Roughly. It's a little less than half, but we'll see. I think they took a big gamble on the other printer they were working with, and didn't have a lot of people picking it up like they thought they would. So they've got a lot of money invested into it, and they need to get it out of it. So the price might come down. Remember, when I bought my initial Asiga, it was $3,500 more than the second one that I bought, and it's the exact same printer. Nothing physical has changed about it, just software
Yeah.
and firmware. So the price will come down over time, and it'll be a little more.
And
You'll be able to get into it a little easier.
Yeah, and I know that here in the next couple of months we're going to see more and more denture materials come out, and the strengths are just improving with each material that comes out, and it is starting to become a competitive market, but in a good way, and everything keeps improving. I did have a text in question from our viewers, and so this person actually just asked, have you ever tried printing this as a monolithic unit instead of tooth and tissue, instead of just having just a monolithic denture and then characterizing after? And if you have, does this affect the fitment in any way? Do you think it would maybe increase the fitment?
So actually, yes, there was a photo in one of my slides. I'm trying to find it. Of a monolithic that had been this one.
Okay, there we are.
So this was a monolithic that had layered traditional acrylic on the facial surface of it. It's just very time consuming to me for my technician to spend that time, and I don't love what the ultimate result. It works. It's aesthetically pleasing for the patient, but like I don't like the finish on it so much.
Yeah.
It seems a little more like it would harbor bacteria and things like that. So yes, I have done the monolithic ones, and they work just fine. And I will tell you, a lot of these patients are not going to be upset if they left with nothing but white. Like they at this point, like being able to drink and eat and speak are superior to aesthetics on some degree.
Yeah.
And I think if you explain that, they would be amenable to that.
Yeah. Do you feel that there would be a difference in strength between the two prosthetics?
Most of these are beefy enough that I'm not worried about them breaking.
Yeah.
Like there is a lot of volume there, and I will tell you that little hollowed out area in the bulb that we created that was already there in the previous prosthesis, the supports that got down into that, I bent a buffalo knife trying to dislodge the supports out of that centerpiece. And that was before I cured it. That was right out of the cleaning solution, trying to get it all apart so that I could cure it. So these resins are extremely strong.
Yeah.
Especially in that volume.
Yeah. That was good. We did have another question come through our messages. It says, how many obturators do you deliver per week? Just to have an idea of how common these cases are.
So I talked to, when I talked to Dr. Yo at UK, I was like, he's an Asian male. He is in central Kentucky. It's not a very diverse. I mean, we have diversity here, but it's not like super diverse. I'm like, Melvin, why the heck are you in Lexington, Kentucky? It's like, oh man, I just follow the cancer. So the cancer in this region is significant. Melvin has a federal $1 million grant to the University of Kentucky to educate Appalachia region about oral cancer. So it is more prevalent in this region than it is going to be in most places in the United States and across the world.
Yeah.
But for me, I will see, I saw one patient yesterday. I'll see a patient of his every other week. I'm not delivering something every other week, but I'm seeing a lot of his patients. So we're seeing quite a few of these patients who need these types of prostheses in Kentucky. Now that is not a national, I wouldn't expect to see that everywhere.
Yeah, that'll be different, depending where you're at around the world.
And also a lot of the patients that I see who need these services aren't from Lexington. Yeah. These are patients are driving 3 hours to get to Lexington to have these services. So that's why I bend over backwards when he calls and says, hey, I have a patient in the clinic. Can you see them today? Absolutely. They drove 3 hours to be here to see you and they need to see me. I'm not going to make them come back unless I absolutely cannot physically see them that day.
Yeah, that comes down to that care for your patient and trying to make a difference.
Yeah.
Um, we have one more question. It says, do you cure in a heated glycerin or a normal light cure oven or curing chamber?
I have tried some of the glycerins. What I have trouble with the glycerins is having the something to put it in that's big enough, or that my curing unit is big enough to hold that and whatever I'm curing, because that prosthesis was pretty large. So that was not cured in glycerin. But if it's a smaller prosthesis, I have some glycerin, and sometimes I'll put the prosthesis in a bag around the glycerin and then cure it, and that will help prevent it from getting sticky on the outside. But normally we are not routinely doing that extra step of the glycerin. But I think it's a good idea if you have the curing unit and everything that kind of works with that.
Yeah, and just to add to that, having glycerin, whether it's heated or not, in the light curing unit that you should use, especially with this type of device, because it is a intraoral biocompatible device. That exact scripting of how to handle it needs to be followed from the instructions for use, just to make sure your patients, properly are cared for.
If it's not listed in the instructions of use, it's a violation of the certification to do it. Would that be correct?
Yeah.
With all this FDA stuff, I'm in a unique scenario where I'm testing things and I'm a clinician. So I have a little more versatility on some of that FDA stuff, because I can say, well, this is the resin I want to use for my patient, and this is what I'm going to use.
Yeah.
Well, as a laboratory, you don't always have that leverage, I would call it.
Yeah.
I don't know if that's the right word, but
you get to prescribe what the patient
I can
needs.
prescribe off-label a material for the patient because it's my patient. Now I can't do that for Joe Schmo or Dr. Schmo's down the road. I don't think I can do that for his patient, but I can do that for my patient. And so I do have a little more flexibility on that. And I'm not saying that's fair or not, but it does give me the ability to help my patients a little bit more sometimes.
Yeah, that's great. Just one thing real quick, Dr. Stapleton, I see you have on your screen, you have your contact information, just so people can see it, your actual, if you want to close out of your question box.
Oh, you can see that question box?
We can't see, no, we can't see the question. It's grayed out, but just so people can see your contact information. And is it okay if people reach out to you if they have any questions about your workflow? Okay, great.
Absolutely. Email's the best way. If I don't get back to you in a week, send it again.
Absolutely. And if any of our viewers have any questions about ASIGA or questions about the workflow from our end, please feel free to reach out to us at info@asiga.com. We'll be able to take care of those questions and point you in the proper direction. Dr. Stapleton, I cannot thank you enough for taking the time. And we went way over that hour time limit, but that's okay because it was such.
Sorry.
No, don't be sorry, because it's such a unique case, and it's important for people to see how these cases are handled and why they're so special, and just the overall technique. Now, I do have one last question. Do you think you could do this without ASIGA, or do you think having that ASIGA Max in your office has made these type of prosthetics doable? Now, this is a stage question, so I apologize.
And I wasn't prepared for your stage question. I'll be honest, I have been spoiled with my ASIGA. So anytime I try to, I have another printer that I showed earlier that I tested out for some folks, and it's a great printer and it'll work in a lot of people's hands. But in my hands, I'm like, where's my ASIGA? I'm like, bring me my printer back. I've seen prints from some other printers, and I'm like, what the heck did they print this on? Because I'm like, the detail is not there. Like on a model, like it's fuzzy, and like the details are not as crisp as what I get on my ASIGA. So I would say absolutely, because when you start up here, like when you come back down here and you're like in this what's kind of middle range, like $3,000 to $5,000 printers, it's not the same. Like it's not comparable. Yes, I could have between my two Asiga Max, yes, I could have 4 of another kind of printer. I don't want 4 of another kind of printer. I'll take my 2 Asigas because of the quality. I mean, really, it's right down to it. And I didn't show this video, but on the other Asiga video, the comment was made that likely if you have a hearing aid, your prosthesis was printed on an Asiga printer. So you guys are very big in audiology, and you've got medical appliances and devices being manufactured on this thing all over the world, and it's just the best. It's one of the best printers I've ever worked with, and I know I'm kind of in my own little zone on that, and got people who disagree with me, and that's okay. Like, you like your printer, I like my printer. It's not always about whatever's the fastest and the cheapest. I like good things. My patients pay good money for me to work on them, and I want to provide them the best product that I can. And that's kind of where I fall with the Asiga printer.
Great, thank you. The question wasn't, I mean, I knew I was going to ask that question eventually, but I'm glad that I didn't have you staged for the answer, so I wanted to hear your true response. And it looks like we have one more question that we'll conclude. It says, do we do, it looks like other companies do like a world summit for 3D printing. Is Asiga planning on something in the future where we could have like all of our guests and customers come in? That's absolutely something that we can entertain, and maybe we should. Absolutely. So that's a great question.
That'd be fun.
Yeah, if we do a world summit for Asiga, or like a Asiga Days or whatever it may be, all of our users and viewers will, of course, will hear about it, because we will announce for sure. We're going to close now. Thank you so much, Doctor, for joining our presentation, and thank you again for everything that you do. And this was great. Thank you.
Yeah, thank you guys.
Take care, everybody, and thank you to all of our attendees.